Doctors often think that all of this risk management either doesn't apply to them, shouldn't apply to them, or couldn't apply to them. That those patterns of marginalisation that are described elsewhere are replicated in medical careers. And that conversation can happen and just knock your career off path completely without you ever knowing that it occurred. I took a really big risk. Nothing should be introduced in a big city facility without a guaranteed aliquot of funding to support the retrieval and movement of non-metro people to receive that service. Talking to a colleague or debriefing a situation that has been particularly difficult is much more normalised now, but it is still not completely normal. Yes, there are individual duties, but there are employers' duties to protect workforce. And this is one that I really do want to call out.
Could you please outline the main streams that your organisation, A Better Culture, has undertaken overall, and what are the main priorities in this?
So A Better Culture was established in response to the year-on-year findings in the medical training survey. And any doctor in training, including IMGs, international graduates who've come to Australia, have an opportunity to tell us about their work, their training, etc. Every year that survey has shown quite high levels of bullying, harassment, racism and discrimination, and for the last couple of years it's collected data on sexual harassment as well. So the project was established under a Commonwealth grant to address those things specifically, and we were given a lot of latitude in terms of how we developed up that scope, but in the end, after a lot of consultation through kind of a large reference group population, we settled on cultural safety, and in particular cultural safety for Aboriginal Torres Strait Islander healthcare workers. All of the conversation about cultural safety, and in fact much stuff about safety in healthcare, is focused on patients, kind of forgetting that the healthcare workers are there as well. And anecdotally, and the research also suggests that Aboriginal Torres Strait Islander healthcare workers feel culturally unsafe at work a lot of the time. And we need to address that if we're going to stop losing the healthcare workers that have so much potential to change the system. So we had cultural safety, and then we had leadership diversity, which was addressing the fact that all of the international health entities talk about a lot, which is that women comprise so much of the healthcare workforce, but leadership is dominated by men. But we started looking at this from an intersectional lens rather than just making it about gender, but looking at as how healthcare leadership doesn't reflect either the diversity of the healthcare workforce in Australia nor the diversity of the population of Australia. And so we looked at leadership diversity. We looked at curriculum. What are the things that could be built into training so that people can learn and grow the right habits, the right behaviours and the right attitudes as they go. And we also looked at workplace health and safety, which has been a neglected area in healthcare for a very long time. It's sort of been taken for granted that because healthcare workers are health professionals, that they'll know everything they need to know to keep themselves healthy and safe, and that will kind of just happen because it will be soaked in. But in fact that's not the case, and there's a lot of stuff for healthcare workers that goes awry. So those are sort of the front of mind things, but we've got a lot of other stuff on our website.
And that last point about the health and safety component, could you talk a bit more about that in particular?
Yeah, sure. So most doctors, and I think I try and avoid generalisations, but I think this one is safe. Most doctors quietly groan on the inside when they hear about occupational health and safety or workplace health and safety, because they equate it with the really annoying mandatory trainings that they have to do around, fire safety, evacuation, click this box. So workplace health and safety has been allowed to develop a really bad reputation with healthcare professionals. And yet when I was working at the UN, I was the doctor responsible for the whole occupational safety and health system, and I got to learn how effective it could be if it engages in the right way with the right entities and at the most senior level. So as the head of occupational health and safety, I had the ability to speak directly to the Secretary General. We don't see that in Australian occupational health and safety, and so that level of influence isn't there. except in industry. If you go to, for example, mining, the heads of occupational health and safety there will have a direct line to the chief executive. That level of influence, and they sit at the C-suite tables. Whereas in healthcare, workplace health and safety tends to be buried somewhere, maybe under HR, often 3 or 4 tiers down. So that's one reason that we talk about it, because we think that healthcare is inherently a high hazard industry, both in terms of the physical environment and the psychosocial risks. One of our bodies of work has recommended the elevation of that, but also hiring expertise, hiring real expertise, not people who've been trained to address trips, slips and falls, but people who've been trained to actually analyse, engage with the professionals as professionals, analyse the actual risks that they're facing, and help them feel heard and deal with issues as they come up. So workplace health and safety, or occupational health and safety, or occupational safety and health, it has many monikers, really needs a rethink in healthcare, and it needs seniority, influence, and the ability to engage intellectually and functionally with people who work in healthcare professions.
And comparing your experience with the UN and your experience with a better culture here in Australia, are there any major differences that you've noticed in terms of the issues that come up with occupational health and safety internationally versus Australia, or are they pretty similar between the two?
I think one of the biggest things that I learned was how much occupational health and safety is embedded in the work culture of many other countries, really embedded. So for example, in some countries, if your organisation is more than a certain size, it's mandatory that your staff have access to an occupational health service. Whereas I think here in Australia, a lot of occupational health is outsourced to GPs. I worked as a GP before I returned to emergency medicine. And a lot of workplace rehab and things is dealt with by GPs. And that establishes a sort of a different dynamic than if there's an actual in-house occupational health expert who can see the patterns of problems emerging in the organisation and can then escalate those to the executive decision-making table. So that fragmentation of effort is one thing that I think I see in Australia, and I'm a big advocate for recognising the strength of Australian general practice, but fragmenting the data is a risk that we take, and there is a benefit when you see patterns. So very early in my career, when I was a very young GP, I was working up the road from a factory, and I happened to be the go-to GP for those factory workers, and so I saw the pattern. I could see the pattern of injury, and so I reached out to that factory's management, and they invited me for a site visit, and I was able to go and see what was happening and work with a physiotherapist to redesign work. But if that pattern is invisible, that meaningful intervention can't be undertaken. So that's one thing that I saw. The other thing, as I've mentioned, is that conduit and respect within senior leadership. Now, I'm not pretending for a moment that everything is sort of, rainbows and flowers in the work that I did at the UN. There were some real challenges there. But one of the things we learned was that risk management can't come, so physical risk management or security risk management can't come at the risk of psychosocial safety. So if people are in a high hazard environment, you can't just lock them in a room without respect to how that might impact on their health and psychological well-being. So I think it's that idea of dedicated services that can really know the industry and know the people, can spot patterns and alert the system to them, and can be a voice at the table that represents the perspective of the workers but is not necessarily an advocate. And one of the other things I learned is that when that's done well, unions and occupational health become very, very influential and incredibly useful partners at the table, rather than necessarily unions being seen as an obstacle that need to be managed around. In the space of advocating for the health of workers, they've been the bedrock of it, as is seen by their engagement and respect with the ILO.
Okay, and in terms of the progress that Australia is making, what are the different trends that you see that Australia is doing well or moving in the right direction in this space?
Here I would give a huge shout out to Safe Work Australia, who have published some amazing things in the last few years, and the most recent one has only come out 5 days ago, and I'm really excited about it. So when I returned to Australia after working in the UN, where I had sort of, occupational health was embedded everywhere, and I returned into the COVID response, and I was really shocked that there were no occupational physicians at the table. Where is the occupational risk management here? So over the last sort of 3 years, I've seen Safe Work Australia publish, first of all, a model code of practice for the management of psychosocial risk, which was a really groundbreaking document, and that has been picked up and is now influencing the actions of boards and employers around the country. The second one was that about 8 or 9 months ago, they actually published a model code for the health and care industries. The first time anybody has specifically talked about the fact that the health and care industries have specific challenges in implementing safety and health for their workforce. So big shout out to them for that. And then just 5 days ago, I think it was, I saw them release something about a model code of practice for the management of biological infectious risks, which for me is just astounding when I think about how cavalier we are about, when you start off as an early career doctor, you're just told you're going to catch things. It's just seen as part of the job. And now that's being recognised that there's an employer's duty to protect you. Yes, there are individual duties, but there are employers' duties to protect workforce. So I'm a member of the Safe Work Australia fan club. I think they've done great work, but what we need now to do is to take all of that wonderful intellectual work that they've done and have it translated into positive actions on the ground.
And you touched on the concept before, but I'd like you to expand on it. The concept of psychosocial safety, what exactly does that mean and entail?
So the Safe Work Australia guideline or model code on psychosocial risk and psychosocial hazards describes how the many different things in a workplace can cause harm, such as the obvious things like bullying, harassment, etc., the things that I was originally recruited to deal with. But then there are also things like the pace of work, isolation, work demands, lack of autonomy, poor change management. All of these are listed as specific psychosocial hazards, and each of them needs to be identified and mitigated if you're going to put in place a risk management plan. People often confuse it with the term psychological safety, which is, I think Amy Edmondson from Harvard was the first person to talk about this. Psychological safety is definitely a part of psychosocial safety, but it really talks about the team environment and whether people feel that they can put their concerns forward, obviously in a respectful and constructive way, and not suffer for that. And that's an incredibly important element in healthcare, because often the least powerful person in the team is the person who's closest and most able to see the risk. And so psychological safety is an important part of it, but psychosocial safety is the occupational health and safety term.
And you've been known to coin a specific phrase in the past called occupational health and safety, like DOC at the start. Could you talk about what that is and what it means, particularly for doctors working in Australia now?
So I coined that term as sort of a bit of a joke really, but to confront the fact that doctors often think that all of this risk management either doesn't apply to them, shouldn't apply to them, or couldn't apply to them. And yet if we were to engage really proactively and start identifying the things, what are the things that make you feel unsafe? So for example, we've known for a while that women who work in operating theories when pregnant are more likely to experience pregnancy loss. That's a classic occupational health risk. And it is something that's being dealt with, but there were years when it wasn't. And the doctors at the table were not really the ones that got that dealt with, it was the nurses, because the nurses were more likely to engage, and the doctors didn't want to risk their careers by asking for special treatment when they were pregnant, because that's, in the bad old days, that was a death knell. So occupational health and safety was my way of trying to invite doctors to the table to recognise that occupational health is in and of itself a medical specialty with experts who could help us with this, but we never seem to invite them to do that. And so shout out here to the occupational and environmental medicine people in RACP. We desperately need you involved in this because they are the real experts.
And one point you touched on is that a lot of the times, particularly doctors who are working in early career or earlier stages in their career or specialisation pathways, a lot of the time they may not feel as empowered as they should be to speak up, either when they foresee an issue or they are feeling or dealing with an issue. Could you talk a bit more about what can change or improve in the system, or particularly in the healthcare culture, to allow this to be empowered?
So we did a lot of work with early career colleagues around this, and also looking at it through the lenses of small specialties or locations with a very small number of people. And we identified a couple of things. The first one, and this is one that I really do want to call out, is that there's been a normalisation in medicine of quietly talking about people behind the scenes, so bypassing the formal reference checking processes, which early career colleagues have a right to see the reports, and they have an ability to rebut or declare if there's been a conflict of interest. Whereas at the moment it's sort of considered normal for someone to pick the phone up and go, look, off the record, what do you think of Joshua? And that conversation can happen and just knock your career off path completely without you ever knowing that it occurred. And so one of the things that we've asked for is for the colleges, the medical training colleges, to very assertively say that that's not okay. We don't want that happening. If you have something that you want to say about a trainee, say it formally, preferably discuss it with them, but don't have sort of secret whisper campaigns. It puts too much power in the hands of an abuser. And in particular, you know, if I would highlight one particular area of vulnerability, if you've got a trainee who rejects sexual advances from a more powerful person, at the moment that person can hide behind a whisper campaign, and that just has to stop. So that's one thing that we talked about. The second thing is that based on the feedback we got from people about the smallness of many of the communities in some of the specialties, there was a real sense that confidentiality could not be preserved if they made a notification about behaviours that were either illegal or unsafe. And we landed on recommending a model similar to what's currently used in Sports Australia, which is an independent body, so that people can make a notification at an arm's length from either the employer or the training entity. That way we would have some data. It might be handed back to the training or employing entity to handle, but there's an opportunity for data and accountability. And also something similar was set up in Parliament as well. But we don't have that level of arm's length or that level of transparency. We have no idea how many sexual harassment complaints amongst female trainees or male trainees, or the most vulnerable group, the gender non-binary trainees. We just don't have the data except for what they report in the medical training survey. So we see real benefit in an independent pathway, and we see benefit in that pathway having some sophistication in it, because sometimes people want to report because they just need support, but they know that if they report it will unleash the 7 fires of hell, and they'll be stuck in an adversarial process for 5 years trying to prove a claim. Whereas our recommendation was that the process and the response needs to be very focused on the reporter's needs. What do they want? What do they need from the process? And how do we make sure it doesn't ricochet out of their control?
So what is the best way to add additional nuance or additional sophistication to these reporting pathways? Is it that we would have different tiers of escalation, or would it be that different people are involved at different stages? Yes. How do you foresee that translating?
So I think that the first thing is, you know, if I could design my ideal system, okay, I'm going to be Empress of the Universe for a minute. The first one would be that notifications would come in and would be very rapidly assigned to a case officer. And that person would do some kind of intake with the notifying practitioner, first of all assessing if there was any immediate risk to them, and be that either from, for example, thoughts of self-harm if they'd really reached that horrible, desperate point, or was there an ongoing threat in the workplace? So that first thing is, how do we make this person safe, and an intake to make sure that that's the case. And then a conversation with them to really get clarity about what is it that they need and want from this process. And our current mechanisms don't do that very well. Obviously, I can't speak for the entire country and all employers, it's very uneven, but at the moment it's very hackneyed into very strict policies and procedures, and it can just go down a very rigid pathway. So appropriate one-on-one engagement, identifying what the reporter needs, what they want, where are they at in terms of their own resilience in this moment, and what do they have appetite to pursue. They might simply wish to be relocated to a different workplace. You know, that might be all they want, and they may not want anything further. Or they may wish to say, I'm going to be the one who makes this end and decide that they're ready and willing to take it forward. But we should not ever assume that everybody has the willingness or the ability to do that, because we all come from different positions in society and structure.
Yeah, and is it important within a lot of these structures to factor in that specific demographic groups may need additional input, like particularly the marginalised groups?
Yeah. So we did have quite a bit of focus around culturally and racially marginalised groups, and there's layer upon layer of vulnerability, and when you break the medical training survey data down, you can see that there are vast differences between male and female trainees, but also between Australian born and international graduates. Unfortunately, the MTS doesn't yet collect data about ethnicity, but the focus groups and other conversations we did demonstrated that those patterns of marginalisation that are described elsewhere are replicated in medical careers. So a non-binary person of darker skin who speaks English with an accent is going to experience multiple intersectional disprivilege and may need more support.
And I know that, well, fortunately, a lot of these issues are starting to become discussed a bit more, but is there still any groups or issues pertaining to any of these groups that you think are not being discussed enough or needs a bit more awareness brought to it?
Yeah, I think sexual harassment is one. When I first started this work, sexual harassment was not included as a line in the medical training survey. We were not talking about it. It was buried in the data around harassment, because at that point the harassment question included sexual harassment, and there was no way to pull it out and work out how much of this is, and they're utterly different things. They've got different drivers, different impacts, different audience, so the people who are on the receiving end are completely different. So we and a number of other groups engaged with the board, and I'm really pleased to say that then they started including a question on sexual harassment in there. But one of the things that we are not yet doing well is working out where that is coming from, not just sexual harassment, but you know, all of the adverse behaviours that trainees report, because there is a question in the medical training survey that says who was responsible for this, and it lists, you know, my boss, patients, families and carers. And with the general disintegration of civility in society that we are seeing as people bring abusive online behaviours into, you know, the real life town square, early career colleagues are reporting increasing levels of inappropriate bullying, harassing, intimidatory behaviours. And certainly in the space of sexual harassment, there is research that shows that female GPs experience sexual harassment from their patients. So I've sort of intersected two areas there. One is I think we need as a profession to be much more willing to talk about sexual harassment, and I think that we need to have some really big conversations about the behaviours of patients, families and carers towards healthcare staff. And one of the challenges that I repeatedly throw down is, at what point is denial of service okay? And many people I engage with are just kind of completely deer in the headlights about that question. You know, if I'm the only doctor in town and I'm being harassed by someone, am I obliged to continue to provide services to that person? Would the regulator stand behind me if I had been sexually assaulted by someone, you know, down at the pub last Saturday night, and then rock up as a patient? Do they expect me to sit in the room with that person and continue to treat them? Obviously, I don't think that we should, because for two reasons. First of all, it's not safe for me, but it's probably not safe for them, because I'm going to have all of this additional stuff going around in my head. Those conversations need to be had. And I think that we've not yet done a good job at teasing out where the sources of these adverse behaviours are, and it would something that I'd really love there to be future research on. Yeah,
and in a lot of these processes, is there a role for, say, regulatory bodies or maybe even insurance bodies or other sort of support entities to come and support the doctors who are in these situations or navigating a lot of these?
Yeah, obviously the you know, your MDOs are a key place to get advice from. and faced with that situation, I would definitely be on the phone to my MDO going, what do I do? Fred Bloggs is in the room, and I didn't report it to the police, but it happened, because that's going to be a highly probable situation. And there's layer upon layer. And when I was working internationally, I became aware of a case where a doctor made a complaint about a patient, and the patient then made a complaint about the doctor for breaching the confidentiality of the consulting room. No-win situation. So getting MDO advice is definitely something, but I would love to see a partnership, a real partnership, not a sit around the table and talk about it partnership. We've got so many of those in this country, but a partnership between people who can put money and power behind this, because that's what is missing at the moment. We've got so many people like me advocating, writing papers, going and talking, but the people who hold money and power in the system are not coming to the table.
And you talked about even in your work with the UN, the importance of having that connection within the structures between leadership and other parts of the workforce. In Australia, what steps can we do to try and make this these sort of conduits a reality, either within a specific structure with leadership or within or across structures?
So what I think needs to happen, and it was one of the recommendations, we've devoted a whole section in our final report to this, is that we need to be hiring real experts to be the champions of occupational health in the system. And we need to be putting them at the senior decision-making table and establishing for them a structure that can engage at the whole organisation, so that instead of clinicians experiencing that eye roll moment when they hear occupational health, that the branding changes and it becomes the place you go when you're in a pickle. And I don't think it should be subordinate to HR. I really don't, because HR's job, by and large, is to ensure compliance with policies and procedures and to protect the organisation. It is separate. It is a separate thing. And I think that raising the seniority profile, expertise and power of occupational health practitioners in the system would have an amazing impact.
And if a doctor or a clinician or other healthcare professionals are interested in training up to become a potential expert in this area, what are the different steps that they can take to upskill?
Well, that's a really great question, because just this morning when I was out walking, I was thinking about this. So I am a GP by training. I'm also a fellow of RACMA, and I'm a member of ACRM. And one of the things that that ACRM and the RACGP are doing now is recognising advanced skills. And when I reflect on how much occupational health is done in general practice in Australia, I do think that there's a place for developing advanced skills. And certainly there are certificates that one can do at TAFE level. There are certainly, there's training that can be done in risk analysis and risk assessment. But I also think we really need to start thinking about more formally certifying more doctors, perhaps if they don't want to do the full fellowship in occupational and environmental medicine, but giving them a parcel of skills so that they can apply those skills, that really specific knowledge. Occupational physicians learn how to do job analysis so that they can work out which capacities are needed for this job and what are the risks. That's a pretty unique skill set, and I'd love to see that amplified throughout our profession.
And a similar question that's related in a different way or a different area is when we're thinking about the leaders of the future in our healthcare systems, particularly in line with this sort of culture that we're trying to aim towards, what sort of training do these future leaders need to go through, or what sort of areas do they need to be across to be appropriate leaders in the future?
Great that you've asked that, because we've written an entire curriculum. So, and a shout out here to Ria Liang, who's a surgeon. Ria led one of a really dynamic working group that has developed a huge curriculum that spans all the way from early career, including medical students, all the way through to organisational leadership, with enunciating the elements and capabilities that need to be built across the board. If I had to identify, that horrible but sometimes really good one thing question, one skill that I think is absolutely critical to leadership is the ability to seek, receive, internalise and act on uncomfortable feedback. some of the most valuable feedback I've ever received is the stuff that I initially have a bit of an antibody response to and I don't want to hear. And I think that that ability to listen, to change your point of view based on what you hear, allows you to be both versatile in your leadership. It means you can move into different areas, but it means that you won't be blind to the problems. Yeah. One of my favourite examples of that was when there was after another horrible event that happened quite a few years ago at Bondi Beach. There were some race riots, and there was a journalist interviewing John Howard about that, and he put to John Howard that a number of surveys had shown that people believed Australia was a racist country. And John Howard's response to that was, well, that has not been my experience. John Howard was a privileged white guy who would never have experienced racism, and yet he sought to negate that whole, that collective body of wisdom of people who had come forward and said this simply because it wasn't his experience. Yeah. So that's the other thing that I would say is a really critical leadership skill, is the ability to recognise that one's own experience does not define everybody's experience. Yeah. And if someone is telling you something that jars with your world perception, then walk towards that. And be prepared to look at the world through their eyes, because you might see things that lead you into really interesting places.
Yeah. And on that sort of note, Australia is becoming a more and more multicultural and diverse place. And particularly within healthcare, there are a lot of healthcare professionals who are trained overseas and then immigrate to Australia. In terms of improving the culture to be more accepting and inclusive of not only professionals but also patients of different diverse multicultural backgrounds, what can the system do, or what can people change or learn?
So one of the things that I really noticed when I came back to Australia from working with the UN was the absolute zero value that Australian employers generally place on multilingualism. Yes. And yet multilingualism is such an important thing. And I did throw the challenge down to the colleges to give points for multilingualism in their selection processes. Yeah. Because how cool would it be to be able to have a surgeon who spoke Farsi working in a place where that was one of the most dominant migrant languages. Yeah. And we're yet to see it. And I very rarely see jobs advertising, requesting language skills. But language is important, and I think we're delusional if we think that everyone is going to manage to learn English whenever they move to Australia. But it also if we were to look at recruiting for multilingualism to match the needs of our communities, it would send a strong message that we really mean it when we say we value them, instead of it feeling a bit tokenistic. Yep, there's always the interpreter service, but it is different. Yeah. It is really different. And being able to speak a language gives you a much better access to understanding the culture, nuances and norms of that. So I'm a big fan of multilingualism, and that probably means I'm a complete UN nerd, but such is it. Yeah.
And I think going on to a related topic, people associate a lot of discrimination as being racial or racist discrimination. But are there other areas of discrimination, particularly in healthcare, that you think aren't addressed enough or aren't known about enough?
I think one is what I think ACRM, the College of Rural and Remote Medicine, were the first that I'm aware of to use the term, and that's geographic narcissism. And it is the perception that the people who work in the big flash city hospitals are the best, and that the people who work in the smaller rural and or remote places are there because they couldn't cut it in the city. Yeah. And there's and that's actually just really wrong. It's not true. I remember once a few years ago when I was in another job, I contacted the director of intensive care at a small regional hospital to ask him to join an expert panel that I was assembling. And honestly, he almost, I'm not kidding, he almost wept on the phone. He said, I've been here now for 4 years, and you're the first person who's ever approached me as though I have anything of use. He said, people just treat me as though I'm an idiot because I chose to come here and serve a rural community. Yeah. And so I think we've really got to challenge that for two reasons. First of all, it's terribly unfair to the colleagues who currently work in rural and remote and regional rural and remote communities. But it also means that colleagues see risk in taking up those roles. They risk that it will damage their reputation and their future career prospects. Whereas in fact it can be foundational. I was, back in the last millennium, I was a rural scholarship holder with the Queensland Government, and that meant that I worked in places that other people didn't want to work. But without question, some of that foundational experience helped me be way more effective at the UN when I was dealing with low resource environments. So I think that we've really got to tackle the geographic narcissism in our system. That's definitely one area. There's clearly still gender discrimination there, and I could rabbit on about that endlessly, but it's still very clearly there. I've heard some distressing and very moving accounts from people of colour in our profession about the inherent and flagrant biases that they experience. And I think that, one colleague I recall who was a dark-skinned person with an English accent described how people would engage with him on the phone and their attitude and demeanour would change immediately they saw him physically. That's just inexcusable. So we have to walk towards the racism issue. We have to walk towards the geographic issues, and we really do need to address gender inequity in healthcare.
And to focus on rural and remote healthcare systems, are there, in addition to these issues that you just mentioned, are there any other unique factors about the culture that needs to be strived towards in these systems?
That's very hard to say, because I can't claim to know the totality of rural and remote health. Generally speaking, contrary to what our colleagues in the big hospitals might sometimes think, the people who are working in rural and remote healthcare are usually there because they want to be. There are some people there who are prisoners to the Medicare moratorium, but by and large, people who are working in rural and remote want to be there. And there's an increasing emphasis on growing people in those communities and recruiting and returning them back. In terms of culture, we do see some situations where racism is more likely to be experienced, but the flip side of that is that once an internationally trained doctor establishes them in the community and people get a sense that that person is there for the long haul, they get welcomed with open arms. There is still a bit of a macho culture sometimes in rural and remote, and it can be incredibly difficult for women building a career in that space to access things that their city sisters might take for granted, things like childcare. And so I think that the entire package for rural and remote needs to be looked at. But overall, in terms of culture, I think that rural and remote has undergone, I think, in the years that the College of Rural and Remote Medicine has been working and has really started taking these issues on, there's a bit more of a dynamic and problem-solving attitude there now, which I think is going to define its own pathway forward.
And another issue that is more of a modern issue, particularly pertaining to rural and remote systems, is as digital technology is being more and more implemented in healthcare. Like, we're at an Australian Healthcare Week where a big focus is AI. Especially, and a lot of these technologies are coming in at a faster and faster rate, but they are usually first implemented in city or metropolitan settings. So as this inevitable change is happening to Australian healthcare, where digital health is coming in, how do we prevent, as a system, how do we prevent further inequity worsening between metropolitan and rural systems?
That inequity is breathtaking, and most people are unaware of it. So the city HHSs, the city decision makers, and I was really unaware of it until I returned and started working in a small rural hospital. But I do find it frustrating that millions and millions of dollars will be spent on a single tool for a major metro facility, and meantime, for lack of retrieval services, a small regional or rural emergency department will be left holding a patient who would be in ICU in another facility. So I think that we really need to pay attention to making sure that whenever some new service is introduced, that there is sufficient funding to allow the transfer of patients from rural areas to get access to that service. That's one thing. The second thing is that the support, the financial support for rural people to travel and be in the city needs to be radically re-examined. The amount of money that they get would buy you a half a shoebox in Sydney. You know, it's just ridiculous that we give people so little money when they need to travel to receive healthcare. So those financial issues need to be dealt with. But in terms of equity, nothing should be introduced in a big city facility without a guaranteed aliquot of funding to support the retrieval and movement of non-metro people to receive that service.
Yeah. And you touched on an important point about the patient experience in all of this, and I think the most important reason for culture improving in healthcare is the patient care, or the patient outcomes as well. So, or not the most important, but an important part of healthcare is the patient outcomes. You've previously done a lot of work in trying to improve patient voice or patient role within the healthcare system, particularly the Ryan's Rule in Queensland. Could you talk through about what that work involved and what issues you see now today that we need to address still?
So that work started, I think, back in 2010, so quite a long time ago. And at that time, the whole idea of partnering and co-designing with consumers, I don't even think we had that word back then. And we were floating this idea that patients, carers and families should be able to generate a response when they recognise that things were deteriorating. It was part of a program of work called Recognising and Responding to Deterioration. And we decided, I remember this so clearly because it was a time where I took a really big risk. We set up a workshop where we brought consumers and key clinicians together into a joint workshop. And at least in Queensland, that had never been done before. And people were telling me that this was an extremely risky thing to do. It was going to blow up in my face, that there would be fights, that it would just, and it was like, okay. So we convened this workshop and we brought them all together into the room, and then we separated them into two separate focus groups and got the consumers to talk about the issues that were important to them and got the clinicians to talk about the issues that were important to them. And unsurprising to anybody, there was an enormous amount of overlap on those issues, which we were then able to use to bring the groups together. And contrary to what the naysayers said, it did not come to blows, and we were able to negotiate an agreed way forward that addressed the concerns of everybody in the room. And that was my first experience of really embracing consumer voice. And it is something that is much more normalised now, that whole process of co-design, but back then it was a little bit crazy.
Yeah, and could you talk a bit more about the main concepts that came out of that? So particularly what the Ryan's Rule is, and also about the other processes that may have come.
So Ryan's Rule is named after a little boy called Ryan Saunders, who died in hospital as a result of sepsis. His family could see that he was deteriorating and they kept raising their concerns, but nobody was really listening to them, and Ryan eventually died. We were developing up this concept of Ryan's Rule, and I would have to just say I was the executive responsible, but I did not do the legwork, and I don't want to take away from the credit of the team who did hours of painstaking engagement, including engaging with Ryan's parents to get their permission to name this process after their son. And so Ryan's Rule now is the ability for anyone in a healthcare setting, a patient, a parent, a carer or another family member, to request an independent review if they feel that their concerns are not being listened to. And it is being used, and it is being used appropriately. It is not being abused. Yeah, sure, there's the occasional vexatious one, but the system is not being swamped with vexatious escalations, and it is saving lives, because nobody knows a person better than their own family, and when they spot signs of deterioration, they deserve to be taken seriously, and Ryan's Rule institutionalises their right to that.
And are there other ways that, as a healthcare system in Australia, that we can help to improve the voice of either the patient or the supporting people around the patient, such as their family and friends?
There are many ways. I think that probably the thing that's front of mind for me at the moment is that we just need to have time.
Yeah.
And you know, I guess as I was talking about future health, if we can create systems that give time for the human engagement, we'll do much better.
Yeah.
Where clinicians are weighed down by busy work that could actually be task substituted to AI entities, but the human engagement part, let them have more emphasis on that. I think that would be enormously helpful. Time to speak with relatives, time to listen to their concerns is something that's in really short supply, and I think if we did that better, we would have a better healthcare system. Now, I do know about the data that says that, you know, that people find an AI entity more empathetic to engage with than a real person, but I think that relates only to non-face-to-face engagement. People can't see the face of the AI entity registering their pain. They can't feel the hand that reaches out to take theirs. Those things are really important parts of engaging in a way that delivers human-centred healthcare. And I think we need to find ways to give our clinical staff the time and space to do that.
And final question, on that last point, just looking at it from the other side of the healthcare professionals from this point of view, a lot of the times healthcare professionals have to be in situations that may be traumatic for them, or may be challenging, or they may have to give so much of themselves in a patient interaction. What's your advice for healthcare professionals to self-regulate throughout this, particularly when they want long careers, where they may be in a lot of these sort of situations a lot?
Yeah, that's a tough one, because the recipe for everybody is a little different. I can only talk about what has worked for me. The first thing that worked for me is being grounded with people who are not medical. I think that's a really important part of it, because we can retreat into our own little bubble of perceiving that we're extremely special, and we're actually not. Other people have difficult jobs too, and I think that that's one thing. But the second one is, do have colleagues that you can speak to. I think that the practice of talking to a colleague or debriefing a situation that has been particularly difficult is much more normalised now, but it is still not completely normal. And there are still early career colleagues who feel that they have to pretend that things don't affect them. And that's just rubbish. They always affect you. It's just whether or not you recognise it now or come to terms with it 6 months later when you're not sleeping and your life is falling apart. There are some situations that are more distressing than others, but some situations will uniquely distress individuals. If you have to deal with a patient, for example, who has the same condition of a close relative or friend who might have died from that, that's going to impact you differently. And sometimes you have to just recognise that if you can be subbed out, it's better for someone else to deal with that. So I think that, you know, being grounded with people who are both medical and non-medical, recognising when the work might be harming you is a good thing to do. Physical activity is great, but it shouldn't be used to sublimate emotions. And reflective practice, where you take a moment to think about, you know, what is it that's been hard. One thing that I was lucky to oversee at the UN was a program that encouraged people each day to just think about one thing to be grateful for. And I know that sounds schmaltzy, it sounds really gimmicky, but in amongst all of the angst and feeling persecuted, there is plenty to be grateful for, and that it is helpful to think. It doesn't fix everything, but it is helpful.
Well, I think that's a really great place to end, and thank you for your time.
Very welcome.